A warm good morning to everybody, and I thank the organizers and Dr. GVK sir for this opportunity. ரொம்ப நல்லா போயிட்டு இருந்தது கடந்த ஒரு 5 செஷன் இன்ட்ரெஸ்டிங்காக. அடுத்த டாபிக் வந்து பெத்தோஃபிசியாலஜி ஆஃப் நியூரோபதின்னு சொன்னதும் ரெண்டாவது ரோலாம் காலி பண்ணி போயிட்டாங்க. ஐ திங்க் ஸோ. ஒன் ஆஃப் த ரொம்ப ட்ரை சப்ஜெக்ட் இஸ் பெத்தோஃபிசியாலஜி ஆஃப் நியூரோபதி. நிறைய ஒரு ஈட்டியாலஜிக்கல் ஃபேக்டர்ஸ் நிறைய இருக்குது. லெட் அஸ் see how best I can do and justify this topic. Vandiyappa. So you commonly encounter the neuropathy symptoms for each and every patient that we see in our day-to-day practice. The commonest complications, the initial complication, the presenting complication, even at the time of diagnosis, we see the neuropathy a lot. So let us now see. Yes, thank you. So let us move on to the pathophysiology of the neuropathy. I am Dr. V Ravindranath from Trichy. Diabetic neuropathy is the common complications of diabetes because of the damage of the nerves due to the chronic hyperglycemia on the peripheral nerves. Not only on the peripheral nerves, even the central nervous system is now affected. And this process involves a lot of multiple factors that include because of the high blood sugar level leading to oxidative stress, inflammation, nerve fiber damage. And it involves so many pathways. So many pathways are there, like polyal, just to name a few: polyal pathway, glycation, and altered protein kinase pathway. You can see the subsequent slides showing how many factors play in to produce the neuropathy symptoms. The chief mechanisms involved in the pathogenesis is hyperglycemia, local nerve ischemia, neurotrophic factor deficiency, and the immune mechanisms that are involved in it. So many factors. In the pathways mainly involved is the sorbitol pathway, hexasamine pathway, and the diacylglycerol pathway increase the advanced glycated end products that is seen. So many things. Decreased myoinositol pathway, decreased sodium potassium, ATPase activity. All this is contribute to the diabetic neuropathy in a bigger way. Let us see one by one. So the pathogenesis mainly involves the contribution of the nerve damage chiefly through the polyal pathway. This is one of the first pathway that we should know, each and everyone. Hyperglycemia increases metabolism by increasing the aldose reductase enzyme that leads to the intracellular accumulation of the sorbitol. So you can see because of the hyperglycemic status, the glucose is converted into sorbitol by aldose reductase. But we need myoinositol and taurine for the normal intracellular function. But due to the accumulation of sorbitol, it deranges the functions of the myoinositol and taurine pathway. Thereby, the normal intracellular function is affected. And the depletion that causes not only because of the sorbitol or the myoinositol, but also the reduced sodium potassium ATP activity that slows down the nerve conduction velocity, and the reduction of NADPH to NAD, and the glutathione stores also was much reduced in the cells. That causes the initial pathway to trigger the peripheral neuropathy. And this impairs the cell's ability to detoxify the redox oxygen species and other agents causing the oxidative stress. So only these two pathways are involved, or some other things are there. Hyperglycemia per se that promotes the formation of the redox oxygen species. Not only this sodium potassium ATPase activity, but also the hyperglycemia per se, it activates the promotion of the redox oxygen species by auto-oxidation and glucose and formation of the advanced glycated end products. And the glycation of proteins secondarily leads to the complications by the uptake of these modified substances by certain receptors. And the receptor for AGE products, that's the RAGE, is an immunoglobulin that internalizes these abnormal proteins and causes the cellular toxicity that deranges. And so today, I just want to explain this polyal pathway, hyperglycemia that contributes to the trigger of the polyal pathway. So increased sugar level, where the aldose reductase enzyme catalyzes to the sorbitol molecule, wherein there is an oxidation of NADPH to NADP. And furthermore, the sorbitol is now oxidized to the fructose level with the liberation of NAD to NADH. So this is the main thing that occurs here. And you can see when the aldose reductase activity is much enhanced, when the glucose levels goes up, the affinity of the aldose reductase is very higher when the blood sugar goes up. And whether the sorbitol and fructose alone causes this effect, it's not that. The direct hyperglycemic effect causes the sorbitol to act on the intracellular, and the intracellular osmotic stress is also involved. And not only this polyol pathway, the sorbitol and fructose and the intracellular stress factors are important, but also mainly the increased level of NADPH to NAD, that is very important. That mainly decreases the glutathione level, increases the advanced glycated end products, and increases the diacylglycerol pathway and even the PKC pathway also. That contributes to the increased oxidative stress and the toxic species also. So these are the main two events that occurs increase the oxidative stress and the toxic species caused by the increased level of the NADPH, and NAD is very, very important in causing the peripheral neuropathy. So apart from that, the oxidative stress could be due to even their auto-oxidation of the glucose and their metabolites. So as a result of this, there is increased oxidative stress, AG formation, expression of receptors for the AGAs, and activation of the ligands, and the altered mitochondrial function, and activation of the PKC and other activity of hexasamine pathways. So many pathways are involved in the oxidative stress levels. And this could be due to other factors also, like enhanced free radical formation due to the glucose metabolism, and the deficit in antioxidant defense mechanism, and even the reactive nitrogen species, especially the peroxynitrates levels are increased. So to say, next to this pathways, oxidative pathway, polyol pathway, we got one of the main things that affects the nervous system. One is the microvascular changes that occurs due to hyperglycemia, the microvascular impairment of the vessel wall thickening, and hyalinization of the basal lamina, and there occurs the decreased lumen size also, and the decreased peripheral perfusion of the nerves. Not only the nerves, even the peripheral perfusion of the skin is also affected, and the nerve ischemia is produced. Thereby the plasma protein leakage occurs and the nerve swelling occurs. That causes the increased interstitial pressure and also the capillary pressure to increase. And finally, you can see the fibrin deposition and the thrombus formation. So we get the microvascular complications contributing to the vessel pathology, not only vessel pathology but also ischemia, and then the hemorrhagical alterations also. So this nerve ischemia causes the decreased oxygen and nutrients levels, sensory nerve or hypoxia, and there is that occurs the decreased electrical stability also, and decreased intraepidermal nerve fiber density and axonal degeneration, and myelin sheath damage also occurs via the Schwann cell dysfunction. And apart from this, we get altered vascular regulations also, altered endothelial function, vasodilatation in the dermal vessels, reduced defective sympathetic mediated vasoconstrictions also is one of the main factor. And coming to the channels sprouting, the disturbed action potential can be produced by the damaged nerves endings being interpreted by central nervous system as pain or dysthesias. And the changes in the ion channel expression in the peripheral fibers also causes the hyperexcitability that is far linked with the neuropathic pain. So the upregulation, how this channel sprouting occurs, there is an upregulation of the voltage gated sodium channels. You can say NAV, we call it as a sodium gated sodium channels. And these channels are involved in the generation of the transmission of the action potential. The action potential is transmitted because it is sodium voltage graded. And this can be classified into the sensitive and the resistant factors, TTXS and TTXR. And TTSX channel is the NAV 1.3, which primary function relays during the embryonic development, and NAV 1.37 is constitutively expressed in the peripheral sensory neurons, are both upregulated in the dorsal root ganglion. And of course, NAV 1.8 and 1.9 is also there. They are normally expressed in the peripheral nociceptive neurons, playing an important role in the generation of the electrical activity in the dorsal root ganglion. And reduction of the Na1.8 expression in the following days after diabetes is seen. And the same reduction was detected in NAV1.6 also. This is another TTX sensitive channel that is present in the node of Ranvier. Thus, both abnormal expression and functions of the TTXR and TTXRS sodium channels is linked with the abnormal activity of the nociceptive fibers. Of course, even the calcium channels are affected, not only sodium, also the calcium, also the potassium channels are affected. And the calcium channels can also be misregulated in the diabetic condition. There is an enhanced calcium influx in the sensory neurons, which can deregulate the both substance P and the glutamate release, also causing the nerve damage and the decrease in the nerve conduction velocity. And the resting membrane potential can also be altered by the potassium voltage dependent channels, that's the KV. We call it as the KV. And regarding the current generated by activation of these KV channels in primary afferent, there are two main types: rapidly inactivating A-type currents and slowly inactivating currents. So we can see the sodium, potassium, and calcium channels. All these factors contribute to the decrease in the action potential and the reduction in the nerve conduction velocity is seen. And this is the diagrammatic representation of the sodium channel and the calcium and the potassium channel. And the other activity, you can see the microglial activity. Glial cells play an important role in the pathogenesis of many diabetes, and macroglia, both the things are there, maintain the homeostasis from myelin and provide the support and protection of the neuron cells. Activation of this microglia occurs right after the peripheral nerve injury and responsible for the production of several inflammatory mediators as cytokines, chemokines, and cytotoxic substances, and as nitric oxide and free radicals that promotes to the pro-inflammatory milieu. So these are the pathway. Peripheral nerve injury occurs due to the hyperglycemia, causes the microglial activation in the spinal cord, and there is an increased inflammatory mediators, spinal inflammatory milieu, and there are sensory changes and hyperexcitability that is seen with all the sodium and potassium channels, which I have shown you already. Thereby, you can see the decreased astrocytic function, increased excitability, and the increased synaptic neurotransmitters that causes the spinal sensitization. So this is another mechanism, central sensitization. The DNP may be consequence of both peripheral and CNS changes. Not only the peripheral nerves are affected, but also the central nervous system. It was well described that during the DNP, primary afferents are sensitized in inducing dorsal hyperactivity and neuroplastic changes in the sensory central neuron system. The common occurrence of allodynia in the diabetic neuropathy patients supports the idea that CNS pain processing is also altered, not only the peripheral nerves but also the CNS system is affected, wherein you can see the altered sensation of the allodynia. And of course, there is an increased glutamate release also on augmentation of spinal N-methyl D-aspartate receptors, which generates the increased and more frequent excitatory post-synaptic currents in the lamina 2 also is seen. And cyclic AMP responses eliminate binding protein signaling also is responsible that regulates the NMDA receptors activity that is enhanced in the diabetic neuropathy system. And finally, you can come to the brain plasticity that is important, the functional changes in the pain processing area in the CNS, besides the spinal cord, have been ultimately linked with the diabetic neuropathy. The marked changes in the thalamus, cortex, and the rostroventromedial medulla have been reported in the diabetic neuropathy patients. And the ventral posterolateral nucleus of the thalamus is the main receiving area of the nociceptive stimulation, and the projection neurons reach the thalamus through the spinothalamic tract, which represents a major ascending nociceptive pathway. Of course, the hyperexcitability of the SCT neurons, that is the spinothalamic tract neurons, probably accounts to the hypersensitivity of the external stimuli, and spontaneous pain that increase in the primary afferent activity is seen, and to the plastic changes in the spinal neuron. So the brain plasticity is one of the main factors contributing to the diabetic neuropathy. And this is the diagrammatic representation of this. Of course, we got other mechanisms of the PARP activation, that is NAD, and the depletion of energy failure, and so many other pathways which I have told you. And there are small unmyelinated nerve fiber damages also that occurs in the peripheral neuropathy. And in day-to-day practice, you know the vitamin B12 deficiency and even with the metformin use also, you can see day-to-day in practice, vitamin B12 deficiency may co-occur with diabetes. And although classically linked to the subacute combined degeneration, the peripheral neuropathy can be a presenting features of the B12 deficiency. And metformin is the pharmacological cause of vitamin B12 deficiency, because the proposed mechanism why patients develop B12 deficiency in metformin treated patient, there is a comparative indication of the inactivation of the absorption, alterations in the intrinsic factor level, bacterial flora changes, gastrointestinal motility issues, and morphological structure and interaction with the tubulin endocytic receptor. So these are the factors how we are we are dealing with the patient taking metformin develops B12 deficiency. So patients receiving metformin should be periodically assess their B12 levels, and we have to replace them. So no point in arguing that vitamins is not necessary for diabetic patient. So many forums they talk, no. It is not like that. If you assess the B12 deficiency, you have to definitely substitute vitamins for the patient, and especially vitamin B12. So other mechanisms, metformin treated patients have lower cobalamin levels and elevated fasting methylmalonic acid and homocysteine levels. These are the levels that are affected here. And the clinical and electrophysiological measures that are identified more severe peripheral neuropathy in these patients, with a correlation between the cumulative metformin dose and the severity also. So the interval screening of cobalamin deficiency and the symptomatic replacement of the B12 is mandatory for each and every diabetic population. So to put together all the nutshell, hyperglycemia with the comorbid condition, all these endothelial dysfunctions are triggered, loss of vasodilatation. You develop the microangiopathy and macroangiopathy through various pathways, various biochemical pathways that contribute to the functional changes, delayed nerve conduction velocity, and reduced NBF also. And there's a pathological changes, a loss of nerve fiber that causes the diabetic polyneuropathy. Thank you.